Hi, my name is Todd Barron, and I'm Professor of Medicine in the Division of Gastroenterology and Hepatology at the Mayo Clinic in Rochester, Minnesota. And today I'm going to talk to you about some of the presentations that I will be giving at DDW this year. The first presentation I'd like to discuss is something called extreme biliary endoscopy. And what's interesting about this is extreme biliary endoscopy has not been previously defined. And in fact, that term has really not been used in the literature. In my opinion, it can be extreme from a variety of factors. It could be patients that are extremely ill that normally we would not be doing such procedures on. For example, those patients that are in the intensive care unit, who are on pressure support, extremely ill. That could be considered extreme endoscopy, even though the procedure itself might not be that extreme. Another reason for extreme endoscopy could be that the techniques that we're using are not ones that we normally use for ERCP. An example would be the use of balloon enteroscopy to reach areas of surgically altered anatomy. Other things that could be extreme would be time constraints. For example, cases that are technically very difficult that could require 2 or 3 hours, for example, to complete would be considered extreme endoscopy. So in this lecture, I'm going to cover the breadth of what I consider extreme endoscopy and hopefully provide some tips on things that you could use for your own practice that might not be considered extreme endoscopy for your cases, but you could still apply some of these tips and techniques to your own practice. The next presentation I'll talk about is how I drain pancreatic necrosis. Now, pancreatic necrosis is something that was traditionally done by surgical techniques, open techniques, in fact, that have then become less and less, or what we would consider minimally invasive surgical techniques. Endoscopic techniques for drainage of pancreatic necrosis are still somewhat in their evolution, although this is now having been performed for the last 15 or so years, has developed in the last 5 to 10 years in using what's called direct endoscopic necrosectomy. And so my approach to pancreatic necrosis is indeed direct endoscopic necrosectomy. And what we do is we puncture the gastric or duodenal wall, entering into these necrotic collections. We then drive the endoscope directly into these cavities to then debride or remove the tissue that's within it. So these procedures differ from drainage of pancreatic pseudocysts in several ways. Firstly, we generally don't do transpapillary drainage or just simply drain through the papilla, since the removal of dead tissue is very important to the success of the procedure, and that generally can't be done with an approach strictly by putting a stent in the main pancreatic duct. So again, these patients are almost all transmural, meaning transduodenal or transgastric drainage. Number two, what differs from pseudocysts is that we make very, very large openings into the stomach or duodenum so that we can then drive the endoscope directly inside these cavities to perform debridement. Three of these procedures tend to be rather lengthy in time. Typically 1 to 2 hours is spent on the debridement process. So my approach is to take patients who clearly meet criteria for drainage, meaning that they have patients with what we call organized pancreatic necrosis. This is a process that takes usually 2 to 3 weeks at a minimum after the onset of their acute pancreatitis. It can be much later, but still be what we call organized pancreatic necrosis, even months after the onset of pancreatitis. We reserve drainage for those patients who have sterile necrosis but are very, very symptomatic, those that have large collections that are getting bigger, inability to eat, refractory pain. We also reserve this technique for patients who have pancreatic infection. So my approach again is transmural approach, enter the stomach or through the duodenum, large dilation up to 20 millimeters at the first approach, directly driving an endoscope inside the cavity and grasping necrotic material. My best success for removal of this material has been using a variety of different snares, although we've used baskets, we've used grasping devices. We then repeat the debridements on a scheduled basis. Now that time frame between the first, second, and subsequent procedures is partly based on how much remaining tissue is in the cavity, the severity of illness of the patient, what their CT scan looks like. So there's a variety of factors that go into how quickly or how soon I'll go back in. But usually between the first and the second debridement will not be more than a week. Sometimes it'll be every few days in a patient that's extremely ill that's in the hospital. The endpoint is, of course, complete resolution of the cavity, complete endoscopic removal of the necrosis, and documentation of complete absence of necrosis on follow-up CT scan. In the animation that you see here, the endoscope is passed into the stomach and a large opening is made at the entry point into the necrotic cavity through the posterior wall of the stomach. The endoscope is then driven inside the cavity and the necrotic material is grasped with a grasping device and withdrawn into the stomach and deposited. And this sequence is repeated over and over again during the procedure to remove as much tissue as can be done in one session. The next presentation I'll be involved in is related to endoluminal stenting, best techniques, and best outcomes. In this particular presentation, I will discuss the approaches to endoluminal stenting, the use of fluoroscopy, the use of guide wires to place stents, and what I feel are some of the key points in having the best outcomes with endoluminal stenting. This endoluminal stenting we refer to consists of stenting of the esophagus, the stomach, the duodenum, and the colon, depending on the clinical situation. So endoluminal stenting is generally reserved for patients that need palliation of obstruction of a lumen. So for example, it would be patients with esophageal cancer, with the inability to swallow. Having said that, we are now placing esophageal stents more and more for the treatment of benign disease, such as refractory strictures, for leaks after surgery, and for perforations that are either spontaneous or iatrogenic. Starting with esophageal stenting, the procedure consists of passing through the obstructive lesion, usually with the endoscope, not simply just with a guide wire, to inspect the length of the stricture, to identify fistula, to identify where the anatomic points are, such as the gastroesophageal junction. We frequently use fluoroscopy, although fluoroscopy for esophageal stent placement is not mandatory, as you can pass the endoscope alongside the stent and deploy the stent under direct endoscopic visualization. For the stomach and duodenum, they're very similar to the colon and are slightly more difficult to perform. We pass the endoscope to the site of the lesion, and we don't deliberately try to get across the lesion with the endoscope. If it's easy to pass the endoscope, or easy enough, we will do that. But the main technique that allows success is passage of the guide wire. So we pass the endoscope to the point of the lesion, we advance a guide wire under fluoroscopic guidance, we pass the stent over the guide wire without dilating the stricture, and deploy it under both endoscopic and fluoroscopic guidance after passing the stent directly through the channel of the endoscope. The third location, and the most difficult location in my opinion, is passage of stents, is placement of stents within the colon. The reason that this tends to be the most difficult is that the fluoroscopy tends to be a little bit more difficult to interpret for those endoscopists who are not used to using fluoroscopy. Number two is these lesions tend to not be en face or directly in front of the endoscope. They tend to be around flexures and corners and very difficult to negotiate a guide wire through. They can be very, very angulated, and the patients generally are sicker, especially when they present with acute colonic obstruction. So all these factors make colonic stent placement, I think, the most difficult in any area of the GI tract. But during the presentation, we will discuss some of the key features for successful placement of colonic stents to provide the best outcome for your patient.